Hello everyone, my name is Rashmi Guru, lecturer working at Assam Downtown University under the Department Faculty of Nursing. So today I'm going to take class on the topic cholelithiasis. So what is cholelithiasis? The term cholelithiasis is The term cholelithiasis refers to the presence of stone in the gallbladder, and this term is derived from the Greek word where chol means valve, lit means stone, and liasis means process. So when the stone is present in the gallbladder, we call it cholelithiasis. But if the stone is present in the bile duct, which is your common bile duct, then we will call it cholelithiasis. Coming to the incidence of cholelithiasis higher in women and the person over 40 years of age. Next, coming to the prevalence. The prevalence of cholelithiasis is that gallbladder disease, which is very common in India and mostly we will see in the North Indian community, and the actual number is not known. And in developed world, like 10 to 15% of adults will have gallstone, and gallbladder and biliary related disease occur in about 104 million people, like 1.6% in 2030, and they resulted 106,000 deaths. The next, coming to the risk factors. So the risk factors are age, as I have said in the incidence, above 40 years of age are higher, sedentary lifestyle, then next sex more common in female than male, then use of oral contraception, and also obesity. Next, coming to the causes of cholelithiasis. First causes are idiopathic, which is unknown. Then next is it can be a hereditary, and again age over 40 years, sex again female more than male. Then medication like oral contraceptive and oral steroids, which the woman used to take for weight loss. Then sedentary lifestyle again, obesity, nutritional factor like low intake of folate, magnesium, calcium, vitamin C, and low fluid consumption. And other causes are when the patient is having disease like celiac disease, then lack of melatonin, then hemolytic anemias, cirrhosis, biliary tract infection, erythropoietic protoporphyria symptoms, and also pregnancy and fever and jaundice and itching. Next, coming to the types of gallstones. So there are several types of gallstones you will see. So first we can see cholesterol stone. What happens in the cholesterol? What are the types of cholesterol stone you will see? So this usually look yellow or chalk white color stone, and it's mainly due to the perception of cholesterol in the gallbladder. Between 35 to 95% of stones are gallbladder cholesterol stones. Then next we'll see like mixed stone. So mixed stones are usually contain stone formed by precipitation of cholesterol. That also can be formed by calcium salt of phosphate and carbonyl palmilate, protein and bile pigments. And mixed stone typically contains 20 to 80% of cholesterol according to JCS, that is the Japanese classification system. And because of this, calcium content are often radiographically visible. And next, coming to the bilirubin stone. Here the stone will appear black pigment, and they are small and usually dark and usually numerous. They are composed of bilirubin and calcium salt, which is found in the bile. So these are the certain gallbladder stones you see in the picture. First one is your cholesterol stone, which appears yellowish. Then your pigment stone, okay, dark pink color, and it's like small and found numerous in the gallbladder. And lastly is your mixed stone. Coming to the pathophysiology, so it can be due to any etiological factor which we have discussed. This will lead to cholesterol supersaturation. What is cholesterol supersaturation? Means here there will be excess of cholesterol will compared to the lecithin and bile acids. So excess consumption, accumulation of cholesterol is called cholesterol supersaturation. So this will lead to hypomotility of the gallbladder. Hypomotility means decrease in the movement in the GI. Mostly seen of the here it says hypomotility of the gallbladder. So there is a decreased movement of the gallbladder or the movement of the bile juice, and this will lead to cholesterol nucleation, which means that this liquid will convert into crystal form. Since the fluid, the juice is not moving, so it will, since it's like a stagnant there, due to the hypomotility, the liquid will turn into crystal form. And lastly, next there is the accretion. What happened? There will be hyper secretion of mucus in the gallbladder. When there is hyper mucus, the mucus will trap this nucleated crystal, and this will form into a gallstone. So common signs and symptoms of gallstones are the patient will have nausea, complain of nausea, vomiting, then they'll have a heartburn, then they'll have fatigue, weak, tired, flatulence, pain in the hypochondriac region, then there will be increased body temperature, weakness, and belching. Coming to the diagnostic studies, we have to take a thorough history of the causes, risk factor, past, present medical illness, and also the sign and symptom. Then we have to take complete physical examination where is the pain and all, where if there is no hypochondriac region pain and all. The next ultrasonography is the best to diagnose the gallstone. Then other tests like your blood test, then also your ARCP. The ARCP test to allow the visualization of the gallbladder. And then coming to ARCP, it is the full form is your endoscopic retrograde cholangiopancreatography. The next is we can do our chest X-ray, and also we can do digital X-ray. Barium will follow through. Then come next, we are going to discuss about management. So under medical management, we can start with the drug therapy, and most commonly we can see that we can give a tablet ursa, though the folic acid. That means when we get in the form of tablet ursa 300 milligram, we can give twice daily orally. And this will what happen here when the patient will take it has to dissolve all the gallstones. But the chances like it can be reoccur if the drug is discontinued. And we can also start with the antibiotic therapy to prevent from any infection. Also fat soluble vitamins and bile salts. So we can give morphine in case of pain, anticholinergic to reduce the pain. Then we can contact dissolution therapy, which involves injecting a solvent known as butyl ether into the gallbladder to also help to dissolve the gallstone. Then next non-surgical approach is first of all we can start with the extracorporeal shock wave lithotripsy. So what happened in this case? This kind of surgical approach we can do only if the gallstone is less than 2 centimeters. Okay, and then here what we can do, we are going to give a energy shock wave through your abdomen as water cushion is pressed against the area, and then this procedure will take like 1 to 2 hours. And when we give this extra software, what happened? They will have to break down the gallstones. And at the after this ECSWL, that is extracorporeal shock wave lithotripsy, once it is done, what happened when the stone is broken down into small fragments, then these fragments can pass through your bile duct and into your small intestine through your feces again. The next procedure we can see is your percutaneous cholecystostomy. In this percutaneous cholecystostomy, this will involve what happened? We are going to insert a needle, and then from the by inserting needle, we are going to withdraw some fluid from the gallbladder, and then we are going to insert a catheter through the skin to drain all the fluid. And once the catheter is left in place for weeks, after which gallbladder removal surgery is performed to prevent reoccurrence. As we have discussed in the pathophysiology that there will be decreased motility of the movement of the gallbladder. So what happened? All the fluid start to accumulate, and that fluid accumulation will lead to gallstone. So what happened? We can prevent stagnation of the fluid by removing of those fluid through percutaneous cholecystectomy. The next laparoscopic cholecystectomy. Here we are going to remove the gallbladder by puncturing one or four small punctures in the abdomen, and this under laparoscopy it contains the camera, and also through the four grabs the surgeon are going to dissect the gallbladder and remove it by grasping a forceps. And this is a very safe, as it's screen here, this is safe and procedure with minimal morbidity. I'll show you the pictures how does this laparoscopic look like. Here the surgeon, here you can see there is a retractor and there will be a dissector laparoscope where a camera is attached to it, and then the operating port or dissector where the surgeon is going to dissect it. Next, open cholecystectomy. Here it involves removal of the gallbladder through the right subcostal incision. And what happened here? They are going to insert a T tube inside the bile duct, and from the T tube, they are what happened? This will ensure patency, and they are going to allow the excess bile to drain while the small intestine will adjust. Here, so I'll show you the picture how the T tube is inserted, and see in the first picture. In the first picture, you can see this is a T-tube. Here they have inserted, and what happened under the after T-tube, there is a basket attached to it, and then they are going to attach to the stone. The stone will attach to the basket, and here they are going to, here through the pancreatic duct, you can see there is a endoscopic through your ERCP endoscopy inserted into the duodenum. And then in the next slide, you can see that inserted into the, we have said that inserted into the endoscopic. This is your endoscopic ERCP inserted into the duodenum. They're going to enlarge the sphincter. This they are going to enlarge, they are going to make it big, and then through that they are going to remove the stone. Trigger removal from with basket inserted through here. The stone will be inserted through your endoscope, and they are going to remove it. Next is your transhepatic biliary catheter. So here is used preoperatively in biliary obstruction and hepatic dysfunction secondary to obstructive jaundice. Coming to the other therapies. So those are your surgical, non-surgical therapy, non-surgical and surgical therapy. You can see now coming to the nutrition therapy. As you know, the patient the gallbladder, the bile juice helps in the digestion, right? So once the gallbladder is removed, the patient will have problem in the digestion. So we are going to be so nutrition plays a very important role for this cholelithiasis patient, and we are going to we have to be very keen about it. So we are going to do some major dietary modification for a patient with cholelithiasis and cholecystitis, which is a low fat diet, because again fat will take time to digest in. So if obesity is a problem, then we are going to reduce calorie diet, which is indicated. Low fat diet decrease stimulation of gallbladder. Foods that are avoided include, and some of the foods you can see are dairy products, then whole milk, cream, butter, milk, cheese, and ice cream, fried food with pastries and nuts. This kind of all types of food should be avoided, and soft and liquid diet for cholecystectomy patient post-operative. Then coming to the nursing management. So we are going to do assessment and focus on the patient respiratory status. Why we are focusing on respiratory? Because if the patient have undergone surgery and all, abdominal, since it's abdominal surgery, the patient will have problem in the breathing status. That's why we are going to focus in case of vascular surgery. If traditional surgery approach is planned, the high abdominal incidence required during surgery may be interfere with full respiratory excursion. And the nurse also have to take history like smoking, previous respiratory problems, shallow respiration, persistent infective coughs, and presence of adventitious sounds. Then we have the nutritional status, and also if the patient have undergone any blood test previously, we can obtain all the three. Coming to the nursing diagnosis, first is acute pain related to surgical laparoscopic wound as evidenced by facial expression. Then second, impaired gas exchange related to the high abdominal surgical incision. Then imbalanced nutrition less than body requirement related to indigestion of fatty food evidenced by decrease in body weight, and also deficit knowledge related to lack of knowledge information. Then lastly, weeks of information again related to surgical wound. And what is our goal? To prevent from pain, then we have to give adequate ventilation, maintain nutritional status of the patient, describe the disease process and treatment requirements, and to prevent from infection. And next, post-operative nursing and intervention. So what are we going to do? Once the patient comes from the OT, we are going to place the patient in low Fowler position. An IV fluid will be started, and also nasogastric suctioning tube was inserted. Nasogastric tube probably inserted immediately after surgery for a non-laparoscopic procedure may be instilled to relieve the abdominal distension. And water and other fluids are given about 24 hours, and also soft diet can be started when bowel sound will return to normal. Then for relieving pain, we can give analgesics and NSAIDs and all, and also we can use a pillow or binder over the incision. And next, improving the respiratory. Here we are going to ask the patient to always need to take a deep breathing, coughing exercise every hour to expand the lung fully, and also to prevent from atelectasis, that is collapse of the lung. And also we can ask the patient to do incentive spirometry, which will help in respiratory function. And also early ambulation is very helpful to prevent pulmonary complications such as thrombophlebitis. And improving nutritional status, again here we are going to encourage the patient to eat a low fat diet and high carbohydrate protein immediately after surgery. And also fat restriction usually selected in 4 to 6 weeks when the biliary duct dilate to accommodate the volume of bile once held by the gallbladder, and when the ampulla of water again function effectively. Then next, we can ask the patient to eat fat. Adequate bile will be released after the digestive tract to emulsify the fats and allow the digestion. When the patient will eat fats and all, then this will also contrast. This is in contrast to before surgery when fats may not be digested completely or adequately, and flatulence may occur. And one of the purpose of gallbladder surgery is to allow a normal diet. Then after all that, the evaluation we can say is we can report decrease in the pain and demonstrate good respiratory function, relief from dietary intolerance, and also the infection can be controlled. Next, coming to the complication, we see cholecystitis, then biliary cirrhosis, carcinoma, peritonitis, and cholelithiasis. Then coming to the patient education, for the activity, we can ask them to start with light exercise immediately, take a shower bath after 1 or 2 days, not immediately after surgery, drive a car for after 3 or 4 days, avoid lifting of objects exceeding 5 pounds after surgery, usually for 1 week, and they can resume their sexual activity when desired. Then next, for the wound, we have to see the puncture site daily for any sign of infection. We have to wash puncture site with mild soap and water, and then we can allow specific adhesive strips on the puncture site to fall off. Do not pull them off. Then we can resume their normal diet, and also if they have fat intolerance before surgery, gradually we can start adding fat into their diet in small increments. Then for pain, from If they experience pain or discomfort in the right shoulder from the gaze which inside the abdominal area during surgery, then we can ask the patient to sit upright in bed or chair or walking may also release the comfort. Then follow up. We have to make an appointment with surgeon 7 to 10 days after the discharge, and we can call the surgeon if they develop any sign of symptoms like redness, if they puncture site like redness, tenderness, swelling, head or dryness, and we can call the surgeon if they develop fever for more than 2 consecutive days. And also if they develop nausea, vomiting or abdominal pain, immediately call the surgeon. Thank you.